in particular, the checkpoint inhibitors has been a steady increase in knowledge of how these drugs work, and it works somewhat differently in terms of efficacy depending on the disease you're treating. So, for instance, if you're treating Hodgkin lymphoma or primary mediastinal B-cell lymphoma or primary testicular lymphoma, which have a high expression of PD-L1, then in these diseases, in particular PD-1 or PD-L1 inhibitors, they work very efficiently as single agents. We know that you had the approval of 2 PD-1 inhibitors for Hodgkin lymphoma that's relapsed post-transplant and brentuximab vedotin. However, for other diseases such as multiple myeloma, for instance, we know that PD-L1 expression in multiple myeloma cells is not as high, and the PD-1 expression, the T cells infiltrating the myeloma cells, is not as high as other diseases as well. And there's significant evidence that PD-1 inhibitors as single agents for myeloma, for instance, are not as efficacious. And other kinds of lymphoma kind of in between. Acute leukemias also sit in between. So, we're looking at providing better response rates with combination. Even for diseases like Hodgkin lymphoma, there's data now combining brentuximab vedotin and nivolumab, both together for salvage therapy, and the response rates, the complete response rates we've seen with the combination are higher than either single agent alone. So showing that there's definitely synergy between different agents and different methods of immunotherapy. However, we also have to be cautious because there's data now of combination of PD-1 inhibitors and immunomodulatory agents such as lenalidomide used in multiple myeloma in the keynote studies that increased the risk of death for other causes rather than the disease, to a point that the FDA is halting combination therapies with PD-1 for multiple myeloma at this point. So the knowledge is still, there's still a lot that we need to learn, but definitely is an exciting arena to study.